Thanks for the invitation. So Vic asked me to do a talk on prostate cancer. That's kind of a big topic. So we'll try to get to all the pertinent details of prostate cancer management for at least 2018. Obviously, it's changing rapidly, but we'll try to get some of the up-to-date information to you today and try to keep on time here. All right, so obviously PSA screening, kind of a hot button issue. It's been a hot button issue for the last several years. But overall, as this graph shows, there's basically been a decreasing mortality rate for prostate cancer since the late 80s. It's been dropping rapidly, and the incidence over the last several years, you can see at the end of that graph, has dropped down as well, and that's thought to potentially coincide with some of the government recommendations to limit screening practices. But now that's, as we'll talk about, that's kind of coming back around a little bit. So the issue that was raised was, are we over-treating prostate cancer? Are we being too aggressive, doing annual screening and so many biopsies and so many surgeries and so much radiation for fairly insignificant cancers? So that certainly was the impetus for the government looking at this. I think they kind of overreached a little bit and came out with a rating, and we'll talk about in a bit, basically saying don't screen anybody. But certainly trying to avoid over-treatment and over-diagnosis is beneficial for patients. And just there's multiple good trials, well-designed trials showing benefit to PSA screening. It still remains controversial. And screening recommendations have changed a lot over the last few years, from the U.S. Preventative Task Force, the American Urological Association, the National Comprehensive Cancer Network. You know, they update these things regularly because it's been changing rapidly and they're trying to keep up. So this is one of the better studies out there. We're not going to talk about too many studies today, but I think this one's important. This is called the Swedish Randomized trial. In Europe, they've a lot of national healthcare systems, so it's much easier for them to get good population-controlled studies. It's much harder to do that here without a nationalized health system. But in any case, starting in '94, those 20,000 men were randomized to getting PSA testing every 2 years, and then the rest were not offered PSA testing. And their PSA threshold to do a biopsy was between 2.5 and 3, and their follow-up was 18 years. So this is a good long-term study, very hard to do in the United States. And it's, as I said, there's no screening in the control group. It has very long follow-up as far as prostate cancer goes, and the PSA threshold for biopsy was also the lowest of most of the large studies. So in the men who had screening, there was a 42% decrease in prostate cancer death. So clearly, that's a pretty significant benefit in an actually randomized population where they actually have a good control group in a national healthcare type system. So for those reasons, you know, this is really the study that should be looked at. It's not always a study that the government does look at, but, and they also talked about surveillance for some patients who were diagnosed with prostate cancer was chosen by almost half. So just because you find prostate cancer doesn't mean it has to be treated. So as far as over-treatment goes, there's always the possibility of active surveillance, which we do a lot these days, but you know, 42% decrease in prostate cancer death over 18 years is pretty significant. So this was called the PLCO trial. It's a prostate, liver, colon, and ovarian screening trial that was cited primarily by the U.S. Preventive Task Force in making their previous recommendations not to do PSA screening. This is an apt title for this slide because it's garbage in, garbage out. So basically it's a poorly designed study for multiple reasons, but the main one is about 90% of the patients who were in the quote-unquote control group actually had PSA testing done before they were admitted into the trial, or actually even during the trial. It was basically the test group was PSA every year. The control group was kind of do what you normally do as far as your doctor's concerned, which may have included PSA screening. So if people are getting PSA screening in the control group, clearly you're not going to see much benefit to PSA testing. So it's kind of a busy slide on the bottom, but basically kind of shows all the number of PSAs that were done in the control group, which was significant. So this was not a very good study, but this was one of the studies that didn't really show any significant survival benefit to prostate cancer screening, and often cited by those who are against prostate cancer screening, but it's a poorly designed trial. So using that trial in 2012, the United States Preventive Service Task Force basically came out giving a D recommendation to prostate cancer screening, which theoretically would mean that Medicare would not have to pay for it. Now, luckily, during the Obama years, they continued to pay for it, and it's been pretty much paid for through that time, but a lot of times you have to justify it, or they'll only pay for one a year, things like that. With some pushback and some additional data like that Swedish study, finally this past year, or earlier this year, they updated their recommendations now, saying that men who are 55 to 69, PSA was then given a C grade, which basically indicates that it should be shared decision making. So this is something that that doctors shouldn't just order routinely with their labs and chemistry panels and blood counts and things like that. They should discuss it with patients first. Now, clearly, with medicine being what it is, and everyone's trying to cram in as many patients as possible to make their RVUs, and they're not going to have a long time discussing high blood pressure and diabetes and cholesterol and everything else to have a lengthy discussion about the pros and cons of PSA screening. So the whole shared decision-making concept is great on paper, but in reality, is that really happening? Not necessarily, but that's what their recommendation is. And then for men 70 and older, still remains a D grade, which I certainly don't agree with. There's certainly plenty of 70-year-olds who are or 70 plus, 80-year-olds that are a lot healthier than 50 and 60-year-olds in a lot of cases these days. So still controversial, but I guess baby steps forward is what's going on right now. So they still primarily focus on overall survival rather than quality of life, and that's a thing that the AUA has kind of been pushing the last several years since these guidelines had changed. That you shouldn't just focus on overall survival, as most of them, I'm sure that a lot of people don't die. The saying is people die with prostate cancer, not from prostate cancer. However, if you have metastatic disease and you're on hormone therapy and you're on all sorts of other medications and you have bone metastases, that's a significant impact in quality of life. So if you can diagnose something early and take care of it, then you can avoid all those morbid and potentially expensive treatments. As far as screening tools, the NNS, that means the number needed to screen versus the number needed to diagnose. So this is basically to prevent one person from dying of disease. So as far as prostate cancer, PSA in the various studies is between 139 to 503 patients that are needed to screen before you prevent one prostate cancer death. Versus mammograms, which are around 377 in the 60s, 1,300 in 50s, and colorectal cancer with fecal blood about 1,100, flexible sigmoidoscopy 49. So you can see PSA does compare pretty favorably to other tests that are widely done for screening. So what do the AUA currently say? Basically say less than 40 years old, they recommend against routine screening. 41 to 54, there's no routine screening necessary if average risk. If you're not average risk, that would include people with a family history, or if you're African American, then certainly you can do earlier screening. On the 55 to 69 age group, they basically echoed what the Preventive Task Force says with shared decision making about the risks and benefits of screening. And then they've said an interval of 2 years may be preferable to annual. Again, that's a good recommendation, but sometimes hard to have patients remember, do something every 2 years. Life expectancy is less than 10 years, no routine screening, so at least they're giving a nod to older patients who are in great shape and still active and might live to be 100. So in that case, you should still check them at some point. The National Comprehensive Cancer Network for 2018, 45 to 75-year-olds. If their PSA is less than 1, they said repeat at 2 to 4 year intervals. If the PSA is 1 to 3, repeat 1 to 2 year intervals. And if the PSA is greater than 3, or if they have a suspicious exam, you should consider biopsy or doing some prostate cancer biomarkers, which we'll get into. If they're age greater than 75, should only screen very healthy men with minimal comorbidities. If they have a PSA less than 4 at this age, a normal exam, consider every 1 to 4 years, and PSA greater than 4, consider biopsy or again doing the biomarkers. So busy slide here. This kind of just summarizes what we just talked about as far as the 2018 guidelines. So indications for biopsy. So basically if the PSA meets any of those thresholds, the first thing you want to do is repeat the PSA. There's been multiple studies showing that one PSA elevation could be an aberrant reading, so you always want to repeat it just to make sure it's for real. Make sure you do your exam. evaluate them for benign disease as well, consider biomarkers. We'll also get into the MRI, multiparametric MRI can be very beneficial to help not only in answering the question, is there significant cancer, but also helping with a guided biopsy if there is something suspicious there. And then to give them the option of going ahead and doing a biopsy versus just having close follow-up with another PSA and exam. And as far as biopsies go, the recommendation is to do a 12-core biopsy or possibly an MRI fusion biopsy, which we'll talk about. But occasionally I still see some patients coming in to see me with second opinions with a 6-core biopsy. That's really not standard of care in 2018. So should be at least a 12-core biopsy. So some of these biomarkers, there's a few blood tests that are commercially available. There's one called the 4K score, which is a blood test, uses 4 different prostate-specific kallikrein protein assays and goes through an algorithm to try to get more specificity versus PSA alone. The Prostate Health Index, or PHI, is basically a mathematical model using free PSA, pro PSA, and total PSA. These are kind of different variations of PSA. There's obviously the free to total PSA ratio, which has been around for a good number of years. And there's also a few urine tests. There's PCA3, which has been around for a while, and then a couple new tests which just came out this year called Exosome DX or Select MDX. And we'll talk about those. So the PHI was approved in 2012 for men with PSA of 4 to 10. It's validated in European and Asian men. It outperforms the PCA3 urine test for men with elevated PSA. It is mentioned in the 2016 NCCN guidelines. It's not specifically mentioned by name in the new guidelines. They just talk about using biomarkers in general. So that's an option. This 4K score uses total PSA, percent free PSA, intact PSA, and human kallikrein 2. They do that. Those 4 blood assays combined with the patient's age, exam findings, previous biopsy findings, and it's calibrated to predict the risk of Gleason 7 or higher disease, which is the ones we're really trying to find. So the 4K score test result of, if it comes back, for example, on the bottom here, it says 5%, that means about 1 in 20 men biopsy would have high-grade cancer. So the higher the score on the 4K test, the higher likelihood it is that you'll have significant prostate cancer. There's one trial on that. There's about 1,000 men at 26 centers with initial and repeat biopsy, 23% diagnosed with Gleason 7 or higher, and this outperformed the PCPT, which is just another kind of nomogram algorithm for trying to gauge risk by a significant margin. And basically the goal with this and some of these other tests is to potentially avoid unnecessary biopsies. So this was able to avoid 30 to 58% of biopsies with delayed diagnosis of only 1 to 4% Gleason 7. So you basically can skip, about a third to a half of biopsies, and you're only really potentially missing a couple percentage points of Gleason 7. So it is a pretty robust test. Select MDX is one of the new urine tests. It reports the risk of any cancer, and more specifically reports the risk of Gleason 7 or higher. It has a 99% negative predictive value for Gleason score of 8 or higher, 98% negative predictive value for Gleason score of 7 or higher. Has a very good AUC curve, as you can see on the right. It basically is done, so patients come in, you do an exam, a DRE with basically three good rubs on each side of the prostate. I would joke with the patient to see if a genie was going to come out. But after that exam, then they do a urine collection, and then you send that urine off to their proprietary lab, and they do this testing. So I've had some experience with this. It's relatively new, but it does seem to have some good data behind it. Another similar test called Exosome DX, which they call the IntelliScore. This is very similar, except it's non-invasive, meaning that you don't need to do the DRE. I mean, obviously you should be doing a DRE anyway, but you don't need to do it before the urine test. Basically, it's the first 30 cc's of urine the patient comes in with. Has a special little funnel device that kind of closes itself off after the first 30 cc's is done. It provides a single score. It's easy to read and use. It basically is a binary score, so if you're above a certain threshold, it recommends biopsy. If it's below the threshold, they say you don't need to do a biopsy. It's been clinically validated with robust accuracy and sensitivity in large, well-designed studies. And it's genetically based. It analyzes 3 different biomarkers on exosomal RNA that are indicative of cancer aggressiveness. So this one I've used a fair amount recently. I don't have a ton of the biopsies yet to see if it correlates with what we find on biopsy, but we'll keep you posted. But it is very easy to do. PCA3 is a non-coding mRNA in 95% of prostate cancers. It has higher concentration in prostate cancer than in normal prostate. It's present in urine and prostatic secretions, and often associated with tumor volume and Gleason score of 7 or higher. It was FDA approved in 2012 for men considering repeat biopsy. So these things are all available. Exactly when to use them, how to use them, still up for some debate. There's not clear guidelines of which one's better. Obviously, with all these kind of tests these days, a lot of it depends on coverage and cost and things like that. Most of these are covered by insurance to some degree, but patients still can have a significant out-of-pocket expense. I think most of the companies like the SelectMDx limits it to around $250, I think, as a copay, regardless of insurance. But that's certainly something you need to discuss with patients. You can't just go and order these and then have them get a surprise bill, which they'll be unhappy about. So MRI, so multiparametric MRI can aid in investigating, identifying suspicious areas for targeted biopsy. In select cases, it may potentially allow for delay in biopsy, although this is still a little bit controversial. So basically, one good study at the NIH, 1,000 men having biopsies. They did MRI targeted biopsies versus just a standard template 12-core biopsy. The MRI targeted biopsy had 30% more high-risk cancers and 17% fewer low-risk cancers. So you're basically finding more of the ones you need to treat and less of the ones that you can watch or don't really need to know about anyways. The main use of MRI currently is really for previously negative biopsies. So patients had a biopsy before and their PSA keeps rising. Rather than just doing another repeat 12-core template biopsy, you do an MRI first, and if you find anything suspicious, then you do the targeted biopsy. There's a score called the PIRAD score, which is just an acronym the radiologist came up with. So anything, but it's a 1 to 5 scale. The 3, 4s, and 5s are the ones we typically biopsy. So it's recommended to do a repeat biopsy for a 3, 4, or 5 lesion. And the options, there's the MRI ultrasound fusion biopsy, which is still done like a regular biopsy. It's just a computer software that takes the MRI information and matches it up to the real-time ultrasound when you're doing the biopsy. They also have some centers that do in-bore MRI, where you're actually taking the biopsies while the patient's in the MRI scanner. Obviously, that's a little bit more expensive and time-consuming, but that is mainly investigational at this point. Cognitive visual targeting, meaning you kind of see where it is on the MRI and then try to mimic that on your ultrasound if you don't have the Fusion Biopsy platform. And they recommend at least 2 targeted cores from each of the MRI abnormal areas. And if a repeat biopsy is deferred on the basis of MRI, so if a patient's PSA is rising, they were like, I don't really want another biopsy, it wasn't that fun the first time, Vic made it painful for me. Then we need to really document that, because that's a little bit, not quite standard to say, okay, we're not going to do another biopsy because your MRI was normal. Because like any other imaging study, MRI really depends on the quality of the test as well as who's reading it. But certainly with a negative MRI, patients may feel emboldened to say, I don't want another biopsy right now. So as long as you document that risk, that's certainly fine. So we want to minimize overdetection, as we talked about. We don't want to automatically screen everyone. We want to modify the regimen based on their PSA, race, family history. Got to keep up with the guidelines. They change every about 2 years or so. And as I mentioned before, you always want to repeat a newly elevated PSA. We see a lot of patients whose PSA has been normal. All of a sudden it shoots up once. And it's like, oh, well, when did they check this? It's like, oh, when I was seeing the doctor because I had a bladder infection. So that's like the worst time ever to check a PSA. I wish they wouldn't do that, but the primaries always seem to do that. So you always want to repeat it and not just saying, okay, we're going to start biopsying you because you had an elevated PSA while you're being treated for a UTI. And selectively use these biomarkers we talked about. Know when to stop screening based on age, health, and PSA. So if you have some patient rolling in within a wheelchair and oxygen, had a triple bypass, and all these other medical issues at age 65, maybe that's someone you don't really need to worry about what their PSA is. And selectively use the MRI. As I mentioned, you want to repeat a newly elevated PSA. One study of 970 men had 5 annual blood draws, median age 62. If their PSA was abnormal, almost about half or more were actually normal at a subsequent visit. So you don't want to plan a biopsy just based on one PSA at this point. The baseline PSA is valuable on a physician's health study, about 22,000 men. The median PSA, 40 to 49 of 0.68, 50 to 54, 0.88, 55 to 59, 0.96 of men aged 55 to 59. 86% of all prostate cancer deaths had a PSA greater than the median. So if the PSA is less than the median, the risk of lethal prostate cancer over 30 years is less than 1%. So if you check a baseline, it's very low. Obviously you don't want to ignore it altogether, but the risk is less than 1% that that patient's going to die of prostate cancer. As far as biopsy results, according to the new guidelines, so if you have atypia or suspicious for cancer, you'll see on biopsy reports the ASAP, which is atypical small acinar proliferation. They recommend considering biomarkers that may improve the specificity of screening or repeating a biopsy with MRI. If there's high-grade PIN that's multifocal, again, you may want to consider repeat biopsy, but if it's just focal, basically just go back to routine screening. High-grade PIN is really not, in 2018, a cause for a lot of concern in most cases. So as far as biomarkers for kind of after a biopsy, so there's a test called Confirm MDX, made by the same people that make Select MDX, shockingly enough. But it's basically what they call an epigenetic assay, and what they're really looking for is a tumor halo effect. So this is done for patients with negative biopsies, and what they're looking for is areas of increased expression of DNA methylation, which is a sign of rapid cell turnover, so cancer cells are turning over quickly. So if you see increased levels of DNA methylation in any of these genetic markers they're looking for, that may mean that there could be cancer in the area around. Is this thing still working? Okay. Cancer in the area around where your biopsy was, and you may have just missed it. So basically this test can be done on a negative biopsy to kind of confirm that it's really negative. Okay, so this is about as close as you can get to telling the patient, you know what, your biopsy was negative, this confirmed test was negative, you're really negative. So, I mean, it's not 100%, but it's pretty close. Again, cost is obviously the concern, have to be discussed with them, possible out-of-pocket costs for this, but it is a useful test in those cases. So as far as if you do find any Gleason 6 cancer, our friends at University of Chicago Northwestern have combined on a recent study about 7,800 prostatectomy specimens with Gleason 6. In the original path report, Gleason 6 with the T3 A or B in 60 patients, or only 2.1%. They were all re-reviewed by 2 other pathologists, and all the Gleason 6 cancers, the rate of extracapsular extension is less than 0.5%. So 0.28% of Gleason 6 cancers in 7,500 prostate specimens. So it's extremely rare for Gleason 6 to get outside the prostate capsule, and the rate of seminal vesicle invasion was 0. So basically, other large studies have also shown Gleason 6 has negligible metastatic potential. So if it's really Gleason 6, it's highly unlikely someone's going to have metastatic disease and succumb to Gleason 6 cancer. So in most cases, if people are diagnosed with Gleason 6 and they progress and don't do well, probably because it was either read inappropriately and it was actually a Gleason 7, or your biopsy just missed Gleason 7, because Gleason 6 has very little metastatic potential. So as far as active surveillance, which certainly would be a good option for Gleason 6 given the fact that there's such a low metastatic potential, in terms of risk stratification, obviously age is important, their overall health is important, their PSA density, how many total millimeters of prostate cancer they had on their biopsies. So, if you get your biopsy reports back and it says, less than 5% of 2 cores, that's pretty minimal disease. If it's 90% of multiple cores, that's obviously a much larger tumor volume and much more likely they could have missed something. There's also the genomic markers, such as Oncotype and Prolaris, which we'll get into to kind of help with risk stratification. As far as the NCCN surveillance guidelines, very low risk patients are considered to be T1C, meaning it's just found on PSA alone. Gleason Score of 6 or less, PSA of less than 10, and fewer than 3 prostate biopsies and less than 50% in any one biopsy. So basically, if the patient's expected survival is greater than 20 years, these are your guys in their 40s or 50s, you're probably finding this low-grade cancer. So certainly active surveillance is certainly a very reasonable option, even for younger patients. And that typically means PSA no more than every 6 months. I see patients that, they go to their primaries with this and they're getting it every 3 months. It's not necessary. Every 6 months at the most is fine. Exam every 12 months at the most. Potential repeat biopsies, but definitely not more than once a year. And you may want to consider a MRI fusion biopsy in the repeat biopsy setting. Certainly, they do say you can consider brachytherapy or external beam radiation for this low-risk disease if you have a 20-year life expectancy, or surgery. So it's not to say you can't treat low-risk cancer. It's just a matter of you want to counsel the patients appropriately. If they have a 10 to 20-year survival likelihood, then active surveillance is really what's recommended. And if it's less than 10 years, they just basically recommend observation, which is different than active surveillance. Active surveillance, you're really following them closely, you're checking their PSAs, you're doing exams, you're possibly doing repeat biopsies. Observation is more or less you leave them alone for the most part because it's unlikely that this is going to progress or cause them any issues. So as far as biopsy technique, I'm sure you're all familiar with this. So the standard is the TRUST transrectal ultrasound guided biopsy. Normally we do a 12-core, 6 on each side. So this is just kind of an image of what a MRI fusion biopsy looks like with the EuroNav platform. There's a couple different platforms. This is the one we use called EuroNav. So it takes the MRI information and fuses it to the ultrasound image. So when you go do your biopsy, it kind of gives you a target to sample. And oftentimes with these biopsies, you'll still do your standard 12 cores, but then you take 2 or 3 from each of the target areas on the MRI. And this procedure typically does take about 10 to 15 minutes to do. It's a little slower than your typical regular 12-core biopsy. So this is in most cases done with anesthesia with some IV sedation. So it's a little bit more involved, but does give you better results. I'm sure everyone's seen this slide at some point. This is a nice colorful version I found. So basically, Gleason Score, Dr. Gleason from the Mayo Clinic described this a long time ago as far as how to define prostate cancer. So as you move down the scale from 1 to 5, the cells become less differentiated. They look less like prostate and more like nothing resembling prostate. The more poorly differentiated they are, then at the higher grade, more aggressive cancer it is. So as far as the post-biopsy risk stratification biomarker test, so Oncotype is a prospectively validated marker that's an independent predictor of both prostate cancer death and metastasis. It predicts future tumor behavior, helps patients understand long-term prognosis. It's prospectively validated as an independent predictor of adverse pathology, and is the most important and actionable endpoint in individualizing patient management. So patients have a much higher risk of adverse pathology. Those are patients you may want to treat rather than observe. It identifies patients with less aggressive disease who are good candidates for active surveillance, and it helps guide the use of more aggressive treatment for patients with more aggressive disease. So the common places we use this currently is for patients we're planning on active surveillance or they're considering active surveillance to kind of give us one more piece of information to say, yes, this is a good candidate for active surveillance. If the test score comes back on the lower end of the spectrum, then you can feel comfortable that there's nothing you're really missing as far as more aggressive disease. On the other hand, if it is more aggressive disease, then you may want to rethink that. And also the radiation oncologists often use this test to help decide if patients undergoing radiation should get hormone therapy along with the radiation or not, depending on if they have a more aggressive cancer. Prolaris, similarly, is another prognostic test developed which directly measures tumor cell growth characteristics for stratifying the risk of disease. It's a 46 gene expression signature, includes cell cycle progression genes selected based upon their correlation with prostate tumor cell proliferation. Low gene expression is associated with a low risk of disease progression, and if there's a lot of these genes that are expressed, then there's a higher risk of more aggressive disease. So treatment options for prostate cancer in general, obviously active surveillance we talked about a little bit, prostatectomy, either open, there's probably a handful of people still doing open around, but not too many. And then Da Vinci robotic surgery, radiation therapy, there's kind of the standard IMRT, EGRT, there's proton therapy, brachytherapy, combination therapy. So these are just kind of this is a very busy slide, I'm sure hard to read even up front, but just kind of goes through the different risk stratifications. We talked about very low risk previously. They kind of divided to very low risk, now it's favorable, intermediate, unfavorable, intermediate, high, very high, regional, and metastatic. So a lot of different stratifications as far as risk, and just kind of depends on what the pathology shows, how many cores are positive, PSA, all those factors, and based on that, you may or may not want to move forward with treatment. So active surveillance protocols we talked about per the NCCN guidelines, but the protocols do vary by center. Some places do a biopsy every year. I personally think that's kind of overdoing it, but a lot of times those are for research protocols. Typically do a PSA every 6 months, DRE once a year, repeat biopsy, typically every 1 to 3 years or earlier. If there's a cause, like there's a big PSA spike, you may want to repeat it sooner. And if the initial biopsy was done with a standard 12-core biopsy, you may want to do the repeat with MRI fusion technique. So the robotic prostatectomy, I'm sure you've probably seen this slide at some point, but basically, we use 5 little tiny incisions versus 1 larger midline incision. So I think it's like 95% of prostatectomies in 2017 were done with the robot. So it's few and far between doing it open anymore. It's pretty limited to a little more seasoned urologists because none of the residents who are in training right now are even learning how to do open. So I haven't done an open one in 10 years. So this is kind of standard at this point. Benefits, less bleeding for sure. Better continence. That's been shown with data. Better return of erections. That's still controversial. There's not great data for that, but bottom line is the controversy about open versus robotic. The ship's kind of sailed. It's kind of robotic, and that's about it. So typically, day or 2 in the hospital. Excuse me. Patients typically have a Foley catheter in for about a week. Some people do 2 weeks, but main side effects for any prostatectomy: erectile dysfunction, urinary incontinence. So you have to make sure you talk about that with the patients. In most studies, it typically has the best long-term cancer-free outcomes, but obviously depends on age and pathologic factors. External beam radiation, in 2018, if it's IMRT or intensity modulated radiation therapy, it's typically done over 45 treatments. Each treatment takes about 10 to 15 minutes. It may be combined with hormone therapy depending on the risk. You often place fiducial markers prior to starting therapy to help localize the prostate and minimize side effects. Can cause erection issues, but often less than surgery, and also can cause some irritative side effects: burning, discomfort, bleeding with urination or bowel movements. But in general, pretty well tolerated with the technology these days. So proton therapy, of which there's one right down the street. It's the only one in Illinois at the Northwestern Center at CDH. So this uses protons to deliver the radiation versus photons. I'm not a radiation oncologist or physicist by any means, but the idea is that the energy doesn't really spike until it's into the tissue. So with regular radiation, the energy level kind of gets, more of the surrounding structures. It does get to the target, but there's more collateral damage, so to speak. Whereas with the protons, it kind of peaks right at the tissue. Theoretically, therefore, it has less damage to surrounding tissues, but there's actually very limited data to show that there's much decreased side effects. It does work oncologically, it's fine, but I have patients that ask about proton therapy, and I always tell them it's obviously up to you to go investigate, but it still takes the same 45 treatments, and most of our patients on the south side of Chicago don't want to drive out to CDH 45 times, and the data is really not that much. Not that robust to show that the side effects are that much more limited. So in any case, and it's also much more expensive for the system. It is covered by insurance, covered by Medicare, but as far as if you're trying to save the overall healthcare system dollars, it is more expensive. Brachytherapy, This outpatient surgical procedure can be used in focal fashion, which is kind of becoming a bit trendy now, to only place the radiation seeds around the area of tumor rather than the whole gland to minimize side effects. It's currently used for low-risk cancers or combination with external radiation for high-risk cancers. This was very popular, 10, 15 years ago for pretty much everything, but it had a higher failure rate than it should have for the Gleason 7 and higher cancers, so it kind of fell out of favor a little bit with the rise of active surveillance. Obviously, if you put these into Gleason 6, they'll do well, but you probably don't need to treat Gleason 6 in the first place. So in that case, there's not a lot of utility with this, but there are some good studies recently that's showing doing a seed implant along with external beam for a more advanced disease lately. There's some good data on that. So a lot of times it's being used in combination because then it can decrease the number of treatments needed for external beam. Cryoablation is also done. It's not considered standard first-line therapy, although it is done for some patients for initial therapy. It's most often used for recurrence of disease that's thought to be localized after radiation. So this is a outpatient procedure done very similar to brachytherapy, where there's a little grid template. It's kind of like playing Battleship. You do real-time ultrasound monitoring and you place the probe in, you kind of see where it ends up in the prostate, and then the technician kind of helps you plan where to put all the things, and it basically pumps argon gas at high pressure through the needles, and it forms ice balls. So you get a big area of ice that forms. You can see kind of on the, shows up there a little bit. So you get that, for 5 or 6 probes, and basically the whole prostate freezes. So you freeze, thaw, you do 2 cycles of that, and it causes most cells to rupture. And this can have good effectiveness as well, and can also be used in a focal fashion. The main side effect of this one is erectile dysfunction. It really, got to tell your patients it's probably going to knock out your erections pretty well. So biochemical recurrence, so after you've done treatment, the common definition after surgery is a value of greater than or equal to 0.2 above their post-surgery value, which is typically undetectable or should be. And then you do, again, 1 additional confirmatory test to make sure. As far as for patients who've had radiation, what's called the Phoenix definition, which is 7, 8 years ago now, the big radiation oncology consensus conference. They define biochemical recurrence as 2 points higher than their nadir. So wherever they go down to after radiation, 2 or higher plus an additional rise in confirmation afterwards is a biochemical recurrence after radiation. And certainly you need to assess if the recurrence is localized or if it's distant. So if it's localized, you can consider salvage treatment. So if they've had surgery, you can do salvage radiation. If they've had radiation, you could do salvage cryoablation. Androgen deprivation therapy, I'm sure we're all familiar with this, used for higher risk disease or also in conjunction with radiation for initial treatment. The main use if recurrent or metastatic disease. So Leuprolide, which we all know as Lupron or Eligard. I did put Lupron first, Mary. You're welcome. Is a GnRH agonist. So normally your hypothalamus is getting GnRH in kind of a pulsatile fashion, which causes it to release its hormones. So the Leuprolide basically causes continuous stimulation, which initially causes a testosterone surge, but then eventually the PSA and testosterone rapidly decrease, typically given every 6 months, although it does come in 3 and 4 month varieties, but in this day I'm not sure why patients would want to come more frequently for a shot than every 6 months. Degarelix or Firmagon is a GnRH antagonist, so this actually blocks those pathways rather than antagonize them. So there's no testosterone surge, so I typically would use this initially for patients going for radiation just to get that PSA and testosterone down quickly. The problem is it's only available once a month, so most patients would prefer to get a shot once every 6 months versus once a month, but it does work very well. So in some cases, we still do a bilateral orchiectomy. It's pretty rare. Most guys want to keep their testicles, but sometimes there's cost issues or patient convenience issues, patients who are like wheelchair bound or other mobility issues. It may be easier for them just to have the surgery one day and not have to come to the office for shots, twice a year. Side effects of hormone therapy, it's kind of like male menopause, so hot flushes, weight gain, decreased energy, libido, and some bone loss. Which leads us into bone health. Patients who have recurrent prostate cancer who are going to be on hormone therapy, They should be instructed to take a calcium and vitamin D supplement on a regular basis to keep their bones healthy. They should get a baseline DEXA scan to evaluate for their bone strength, and if they do have osteopenia, you can consider adding other bone medications such as Prolia every 6 months along with their hormone therapy. Typically repeat a DEXA scan every 1 to 2 years. And in the setting of metastatic disease, you can use Xgeva or denosumab, which is kind of the more robust version of Prolia, to help prevent pathologic fractures. So moving on to castrate-resistant prostate cancer. So this is basically when you're on hormone therapy, the PSA levels are low, which is defined as less than 50, and their PSA begins rising. So patients should get imaging done per the RADAR guidelines. RADAR is basically was a group consensus experts to kind of figure out when you should be imaging patients with prostate cancer. So they recommend getting imaging if the PSA is greater than 2, and if negative, then the PSA becomes 5, and then every time it doubles thereafter. And this is looking for metastases. And typically you start with a standard CT scan along with a technetium-99 bone scan, which is the standard bone scan that we've been doing for a long time. Even if the PSA is rising, despite being castrate, we don't stop the hormone therapy. So basically these patients should be on their leuprolide or degarelix forever, unless there's some side effect issue, but it should continue even if the cancer becomes castrate resistant, because all the subsequent treatments for the most part rely on a low testosterone to make them work or work better. So for some patients, if you don't see anything on the CT scan or bone scan and you are pretty convinced there's metastasis somewhere, this Axumin PET Scan, Axumin's been around a couple years now, but it just got Medicare approval this year, so it is much easier to get covered now. So flucyclovine or Axumin is infused during a PET scan rather than glucose. A typical PET scan, they give you a tagged glucose injection to look for rapidly metabolic cells, which typically indicates cancer. This Axumin is much more specific to prostate cells than a standard PET scan. So basically you can see these hot spots show up in the bone, or a lot of times you'll see them down in the lymph nodes. And if you do this and it only lights up down here in the prostate, then you can kind of say, oh, this is just a local recurrence, and we can treat it as a local recurrence rather than as a metastasis. So this, we've talked a lot about the hormone pathways. This probably should have been toward the end. Sorry about that, but I'll talk about it now. So this is a ARV7 is another test made by the folks at Oncotype. So basically, all the other treatments we're going to talk about till the end of the talk here are for castrate-resistant disease and manipulating the hormone pathways to try to slow down advanced prostate cancer. So in some cases, there's a mutation called ARV7 splice variant that basically the androgen receptor is always turned on. So if you make their testosterone low, if you block their testosterone, if you block all these pathways, it doesn't matter because there's a mutation and it's always on. So basically, if you do this, if you start a patient on a medication that their PSA should be dropping and it doesn't really drop or drops for a bit and starts flying up again, this is a good test to do, because if it's positive, it means you're wasting your time with the hormone manipulation medications and they should go get chemotherapy. So it basically kind of tells you that the patient needs chemo rather than other treatments. So those other treatments would include the androgen receptor inhibitors, the first generation medications such as flutamide and bicalutamide were introduced in the 90s. The primary side effect for most patients is gynecomastia, and there's really not much clinical evidence to show these really have a lot of benefit. People use Casodex all the time, they still do, but it really doesn't have any good data to support it. So the second generation androgen receptor inhibitors such as enzalutamide or Xtandi or apalutamide or LETA are now approved for non-metastatic castrate-resistant prostate cancer. They both block 3 steps of the androgen receptor pathway, where the testosterone binds to the androgen in the cytoplasm. Once testosterone binds to the receptor, it then normally moves into the nucleus, so it blocks that step as well. And then once it's in the nucleus, it binds to DNA and allows for transcription of various cell growth factors, so it blocks that step as well. So every point along the testosterone pathway, these drugs block it. The primary side effects with Xtandi is fatigue, and with Erlita, you can get a rash. They're once-a-day oral medications, and typically tolerated pretty well and typically have pretty profound effects on the PSA. So metastatic CRPC, Metastatic refers to any bone metastasis or lymphadenopathy outside the pelvis, or if there's any visceral metastasis. So the difference between metastatic and non-metastatic, if there's regional small pelvic lymph nodes, that's still considered non-metastatic. So you have to have either larger lymph nodes greater than 5 centimeters, or if it's outside the pelvis or into other organs or bones to be considered metastatic. So there's multiple medications approved for metastatic CRPC. There's abiraterone or Zytiga, sipuleucel T or Provenge. Enzalutamide is also approved for metastatic. Radium-223, known as Xofigo, and obviously there's always chemotherapy like Taxotere. So abiraterone or Zytiga, it's an oral medication as well that helps to decrease testosterone synthesis. So even if you are suppressing testosterone production from the testicles, there's still some production from adrenal glands, as well as sometimes the cancer cells themselves can start making their own testosterone. So this blocks that pathway. So you need to check labs with this every 2 weeks for the first 3 months. The main potential side effect can be some liver toxicity, so you have to check their liver function test to make sure there's no issues. And it's also taken with prednisone, because by blocking this pathway, it actually causes a decrease in overall steroid levels. So you need to take prednisone to replace it so the body can make its other cholesterol-based steroid hormones that it needs. Enzalutamide or Xtandi, we kind of talked about this briefly. This just kind of is a pictorial version how it blocks the binding of testosterone to the receptor in the cytoplasm. If it does bind, it then blocks it going into the nucleus, and if that still gets past the goalie, so to speak, then it can block the binding of DNA and transcription of those growth factors. Provenge is an immunotherapy for metastatic castrate-resistant prostate cancer. So patients are sent for leukapheresis, and some of their T cells are removed and sent off to Southern California to their laboratory, and they get tagged with an antibody. They then come back and they get their activated T cells back about 48 to 72 hours later. It's done a total of 3 times to complete the treatment course, and the main side effect for most patients is a mild transfusion reaction when they're getting their cells back, but typically pretty well tolerated. So basically, as I mentioned, they get the leukapheresis done. They then tag it with the antibodies, and the cells get activated. So, and then once they get put back into the patient, then the process of the immune system starts regenerating and making a lot more of these T cells, which are now activated to attack prostate cancer and destroy prostate cancer cells. Xofigo is an alpha particle emitting therapy, radium-223, that works at the site of bone metastasis. So this is specifically to help with bone metastasis, exerting an anti-tumor effect. It mimics calcium and forms complexes with the bone mineral hydroxyapatite at areas of increased bone turnover, such as bony metastases. So the alpha particles from Xofigo cause cell death and can be absorbed by other organs. So it can have some other toxicities, but it cannot be administered along with chemotherapy. So if patients are getting chemotherapy or may need chemotherapy, this is not the right choice. But for patients who have a lot of bone disease and who are symptomatic with bone pain, things like that, this can actually have a profound impact and improve their tumor burden and pain control and quality of life. So progression, when patients progress despite all these fancy new medications we have, when the oral oncolytics fail, Provenge fails, Xofigo fails, then typically it's when you refer to your oncologist and they move on to chemotherapy. There's first-line chemotherapies, typically Taxotere, and then there's second-line chemotherapies, or there's obviously clinical trials you can refer them to, pain control, and ultimately for a small percentage of patients, they do succumb to disease and end up with supportive measures. But luckily this is fairly rare in 2018 with all the medications we have available, but still does happen for some patients. So I think that's about it. I have left some time for questions. I know it's a lot of material, but any questions, feel free, and thank you very much. Yes?
Are these medications you just talked about strictly for prostate metastasis?
Yes, currently. I mean, like the Xtandi and Zytiga, Provenge, all those? Yeah, at the moment the indication is only for prostate as far as I know. Could that change? Possibly, but I mean, most of these are Provenge is really specific to I mean, the antibody they use is really specific for prostate cancer cells, protein on prostate cancer cells. There's certainly other immunotherapies that are similar for other types of cancer, but I don't see that being used for something else. And the enzalutamide or Xtandi or apalutamide, those are really manipulating the testosterone production or testosterone pathways. So again, most other types of cancers are not really driven by androgens. So they're probably only for prostate cancer as far as I know. The only exception there is the Xofigo. Xofigo for the bone metastases, that is used for other solid organs that go to bone. Because that's not really specific to prostate cancer cells, it's just bone metastases in general. Yes?
Did you notice when the guidelines first released in the healthcare policy, did you see an uptick in later-stage disease in Alzheimer's?
I think most urologists anecdotally would say yes, whether that's just a bias that we're just mad about the guidelines being changed. I mean, there are some studies that show there was an actual mild increase in new onset metastatic disease. So now that the guidelines have gone back to a C grade, and a lot of primary doctors, especially those that were in practice for a while, I think understood, and they've all seen patients that benefited from it. So a lot of them never stopped. I think the main issue is some of the newer physicians that were not really trained to use it, and also some of the doctors where there's like healthcare systems that kind of tell them what they can and can't do, like big multi-specialty, managed care kind of things, if they weren't allowed to order it. That was the problem, but hopefully it'll kind of move back the other way. But I feel like anecdotally I saw more in the last several years than we did before that. Yes, sir.
These biomarkers, are they being covered by Medicare and then publicly like county care now?
So well, it depends. I mean, which biomarker you're talking about. Most of yeah, there's a lot of them. Yeah, so the ones for like after biopsy, the Oncotype and Prolaris, they typically do have pretty good coverage, but they're also expensive tests. So most patients do have some copay involved. Medicare, like Medicare, for example, does cover most of them, but there still may be some out of pocket even with Medicare.
Obligate like county care, like with the Select MDX and PCA3.
That's a good question. I don't really see a lot of county care patients, so I'm not sure if it gets good coverage, but certainly something you can check with the reps. But I would assume, because for like the EXO test, for example, which is a new test, it's not covered by Medicare, but they want to get their numbers up and they want to try to get the data to get their Medicare coverage. So basically, if you order that on a Medicare patient, then they won't have any. They basically kind of do it for free, more or less, because they're trying to build up their numbers. That happens with a lot of new diagnostic tests, so that are not Medicare approved yet. You order them and they kind of do it anyway because they're trying to get their data. But I know the Select MDX, even if it's a Medicare, they still may have an out-of-pocket. But most of the companies are capping them, so it's just a matter of in your area or with your patient population, talking to the reps and saying, okay, what's the maximum out-of-pocket this patient might have? And they're all pretty good about having patient support lines, things like that, to try to based on income levels, things like that they can help minimize the cost. Yes.
Recommended receiving a PSA with an elevated one, but is there a specific time frame recommended between the elevated one and
Not necessarily. I don't think there's a specific time frame in general. Unless it's in the setting of like I mentioned, if patients have a UTI. If they have a UTI and they've just gotten treated, I normally wait at least 4 to 6 weeks to let things kind of calm down. But if it's just, they feel fine, their urine's fine, they had no UTI symptoms, and they come in, their PSA jumped up from previous years, then, there's really no specific time frame as far as guidelines go. And a lot of times, once you see a patient that's been referred by the primary doctor, their labs have already been, a week, 2, 3 old, so they can get it done pretty much right away in most cases. Yes?
Are there any guidelines as to when to start hormonal treatment when PSA recurs after several years?
Yeah, that's an excellent question. The answer is no. It's always, kind of consider. And it's really conversation to have with the patients. Certainly there's pretty good data that shows once patients have metastasis, that the 5-year survival, decreases significantly. It's probably better than it used to be, but it used to be, from studies a couple years ago, that once you have metastasis, your 5-year survival drops to about 30%. So, that's before some of these other new medications came out, so it's probably not that bad, but it certainly does decrease. So I certainly try to get them started on it before they're metastatic. But there's some people will start them, like if they've had radiation or they've had surgery and their PSA, goes up like 0.5, they're like, oh, you need hormone therapy. I mean, to me, that seems probably a little bit overdoing it, because I always tell people they'll probably need hormone therapy at some point, but obviously those medications have potential side effects. So the longer you can wait, the better, as long as you can get it before they're metastatic. So, and especially a lot of patients don't really want to start right away. I mean, some do. Some are very hyper vigilant and focused on their PSA. So if it goes up like 0.1, they're freaking out and they're like, oh my God, we got to do something. But specifically to say, okay, the guidelines say at this level you have to start, it's not really defined quite that specifically. Other questions? Yes?
Zytiga with the prednisone, that's the only one that needs that additional steroid, need to...
Additional steroid?
Yeah.
Correct. Yeah, yeah, just how it works. So, some people get freaked out, they say, oh my God, I don't know how to deal with steroids. I don't want to get side effects from steroids. It's really not, you're not giving the patient more steroids like you would if they, have some other, autoimmune disease or something like that, where you can get, a lot of side effects from that, but this is just kind of replacing what the medication takes away. So it's kind of a net zero, prednisone. You're not really giving them extra. Any other questions? Oh, wait, one more?
Last question.
What are your vitamin D and calcium recommendations?
Typically calcium 600, vitamin D 400. I think a lot of time, a lot of formulations are kind of like that standard. So obviously it's patient dependent. If they have a history of kidney stones, we don't want to go crazy with calcium. If they have really poor, bad osteopenia on their DEXA scan, you may want to be more aggressive. But it's especially in the patients who are giving Prolia or Xgeva, you got to be very vigilant to make sure they're actually taking their calcium, because if they're not, that's when you can get side effects of those medications. So, I mean, it's good for everybody, but if you're on one of those other two medications, then it's like mandatory that you check and document that they're on their calcium. All right, well, enjoy the rest of your morning. Thank you very much.